You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 2nd, 2018. I want to first apologize for my voice because I have a cold this week. I'm going to talk this week about cardiovascular outcome trials in diabetics, canagliflozin, cardiorespiratory fitness, and 2 stories on medical evidence, including the most important paper, I believe, of 2018. This week, the FDA convened a meeting to discuss its 2008 requirement that all new drugs for type 2 diabetes be tested in RCTs to exclude an unacceptable increase in CV risk, cardiovascular risk. At this meeting, they asked a group of experts to vote on whether to continue this policy going forward. Now, the short story of why cardiovascular outcome trials actually began for type 2 diabetes drugs came from really 3 lines of evidence. The first was that in the ACCORD trial, there was an increased risk of major adverse cardiac events, MACE, with intensive glucose control. Second, a meta-analysis of 42 trials of rosiglitazone suggested an increase in MI and cardiovascular mortality. And third, before 2008, trials for type 2 diabetes drugs were of short duration, and they included lower risk patients, which led to lower numbers of events and thus less ability to suss out signals of increased risk. And since 2008, 8 large cardiovascular outcome trials have been done, and none of these trials have shown a signal for increase in major adverse cardiac events, though a signal for increased heart failure admissions was seen with saxagliptin, and an increase in amputations with canagliflozin, which I'll talk more about coming up. So this discussion led to a narrow 10-9 vote to continue to require manufacturers of drugs for type 2 diabetes to perform dedicated RCTs for cardiovascular outcomes as a condition for U.S. marketing. Now, most panel members agreed on making revisions to the 2008 guidelines. Those who voted for the policy recommended streamlining expensive cardiovascular trials by using more remote monitoring technology or data from EHR. Though I have to say, my personal experience is that I'm pretty nervous about using EHR data due to the quality of that data. But those who voted to stop the trials suggested making the pre-marketing phase 2 or phase 3 trials a little bit bigger so as to increase detection of cardiovascular endpoints. And another interesting discussion point that I hadn't thought about is, will future trials of diabetes drugs be studied against a placebo like they had been, or will they have to be compared against one of the new drugs that have been shown to be effective in the randomized controlled trials? And I don't know the answer to this question I'm asking. So I'm not a diabetes specialist, but it seems wise to continue studying cardiovascular outcomes. I mean, consider if we had not done these 8 trials, maybe we would have missed discovering the cardiovascular benefit from empagliflozin, liraglutide, and maybe canagliflozin. Finally, though, when I see patients with type 2 diabetes in the clinic, I'm struck by the complexity of their drug regimens. I mean, first of all, these patients don't just have type 2 diabetes, they have arthritis and hypertension, or maybe AFib, coronary disease, chronic kidney disease. Their list of medications is often long. And most new guideline statements rightly call for personalizing therapy with shared decision-making. But this means someone is going to have to help prioritize which of these more than 10 medications the patients will take, because I am pretty certain that taking more than 10 medications can't be beneficial. So second topic is on canagliflozin. And in other FDA news, also relating to type 2 diabetes, the SGLT2 inhibitor canagliflozin received FDA approval for reduction of major adverse cardiac events in patients with diabetes and cardiovascular disease. Now, this is a big news because it's the first oral type 2 diabetes drug approved for CV event reduction. Empagliflozin can claim a reduction in CV mortality, and liraglutide can claim reduction of MACE. Now, this recommendation on canagliflozin is based on the CANVAS trials, which are tricky because they were actually a combination of 2 trials, CANVAS and CANVAS-R. The combined results did show a significant reduction in MACE, though barely the p-value for superiority was 0.02. But this reduction came at a price, which was an increase in fractures and amputations. In fact, the drug carries a black box warning for an increased risk of amputations. And the skinny taken from a Sanjay Kaul's summary quote this summer is that for every 1,000 patient years of exposure, treatment with canagliflozin prevents 4.6 MACE events at a cost of 2.9 amputations and 3.5 fractures. And also, I would add that you have to consider the high cost of the drug. I looked it up online, and the cost with a coupon, quote unquote, was around $500 per month. So I may be wrong, but this looks like another flat of the curve, low value therapy. Third topic is about fitness. Now, prediction, I have come to learn, is a tough game. Patients and doctors, we measure all sorts of things to help predict and prevent poor outcomes. I mean, blood pressure, glucose, lipids. We look inside the colon and image the breast, all in the name of predicting a bad outcome. But all these numbers and images obscure the best predictor, how well a person can move and for how long he or she can sustain physical activity. The Journal of the American College of Cardiology published a very neat study from an exercise physiology group in Muncie, Indiana, which is notable for me because I once did 2 half-Ironman triathlons in that city. This group studied greater than 4,000 people over 24 years, and such longitudinal studies are often interesting. And they found that cardiorespiratory fitness, as measured by VO2 max testing, was predictive. Low cardiorespiratory fitness compared with high fitness was inversely related to death, CV death, and even cancer death. And for each metabolic equivalent improvement in fitness over time, there was a 10 to 15% reduction in mortality. So fitness is predictive. Now, I like this sort of study, and I like that it's published in a leading cardiology journal like JACC. It gets clinicians thinking less about super selective high-tech predictors and more thinking about the obvious, which is the overall condition of our patient. Now, I do think there's some debatable parts about this work. For instance, they said that maybe fitness should be a vital sign. And secondly, they suggested that maybe we should do more formal VO2 testing. Now, I don't think we need another vital sign. The 4 that we have are perfectly good vital signs, and we must learn the lesson from the pain is a 5th vital sign debacle. The second issue is, should we measure VO2 max more regularly? Now, I had a patient recently who complained of terrible fatigue, dyspnea on exertion, and he was referred actually for AF ablation, even though he had a really low AF burden. I'm like, no way all these problems are due to AF. Well, another doctor in my group had done a VO2 max test, and the patient was in sinus rhythm at the time, and he found that this guy had terrible fitness and concluded it was due to deconditioning and obesity. So that VO2 max test helped me help this person. Instead of spending tens of thousands of dollars and the risk of AF ablation, I was able to get him going on an exercise plan. So yes, we should think more about fitness, and this may mean having our patient walk down the hall or up a flight of stairs with us, or we should simply observe them from getting up from the chair to the bedside table. For the next topic, I need to deviate a bit from cardiology just for a moment to discuss a very shocking and sad study which highlights the vital need for doing randomized controlled trials in the practice of medicine. Let me first take one quote from a sentence in the paper's introduction. Quote, "A number of factors may explain the difference between the results of our prospective randomized trial and the results of previously reported retrospective studies." Ladies and gentlemen, when you hear that, pay attention. This week, the New England Journal published an RCT concerning a minimally invasive approach to cervical cancer. Women with early forms of cervical cancer were randomized to 2 types of hysterectomy. One type was the type you see on billboards advertised, minimally invasive laparoscopic robotic surgery. The other group got traditional open surgery. The investigators chose rates of disease-free survival at 4.5 years as the primary endpoint, and they put about 300 patients in each group. And here are the results. 86% of women in the minimally invasive arm were free of disease versus 96.5% in the open surgery. That's a whopping 10% absolute risk difference, and it did not meet non-inferiority. In other words, that's a number needed to harm of 10 with minimally invasive versus open surgery. Now, one other item from the paper, also from the introduction, and they say that current guidelines say that either approach to this cancer is acceptable, and these recommendations have led to widespread use of minimally invasive approach for radical hysterectomy. Although, quote, there is a paucity of adequately powered RCTs. So no, I'm not going to go on about any of the details of the treatment of cervical cancer. That message here transcends one medical condition. It's a message about doctors' hubris, our excess confidence in accepting new therapies that have yet to be tested. Cohort studies, small studies, retrospective studies should not lead to widespread acceptance of a new therapy. New approaches ought to be tested. We need the courage to put our beloved therapies to the test. Now, regulators could help us here by more often tying reimbursement to evidence generation. So, for instance, in cardiology, yes, I love his bundle pacing. It's new, it's beautiful, but it needs to be tested against standard pacing. And my gosh, do you all realize left atrial appendage isolation is going on in earnest for an indication, anticoagulation ineligible patients, without a shred of RCT level evidence that it's beneficial. And the last comment I'll make on this is, whenever you hear someone say that they do something or we do this because it's in the guidelines, I urge you to go to that document, go to that paragraph and look at the citation. If that citation goes to cohort studies or propensity-matched observational studies, or even worse, expert opinion, my recommendation is to be skeptical, very skeptical. The final topic today concerns what I believe is the most important paper of 2018, and is perhaps the most important paper of the decade. Professor Brian Nosek runs the Center for Open Science at the University of Virginia. His team has published a study that has forever changed my view of interpreting medical studies. In his elegant study that took years to finish, their group has shown that the choices researchers make in how they analyze a data set can substantially affect the results. Now, for years, when I read a scientific paper, I thought that the data yield the published results. And no, this turns out is wrong. What Nosek and his colleagues have found is that results can be highly contingent on the way the researchers analyze the data. And get this, there is little agreement on the best way to analyze the data. So here's what they did. The research question they chose, and you could choose any research question, but they chose, do soccer referees give more red cards to dark-skinned athletes than light-skinned athletes? Now, they collected huge amounts of data from European leagues, and this data formed a data set. Well, they then recruited 29 teams of researchers to analyze this one data set in any way the teams felt appropriate. I mean, some used Bayesian methods, others used different regression techniques. I mean, literally 20 or more different ways. There were also independent choices on handle the covariates. Now, the teams worked independently initially, but then they came together in this project for round-robin sessions of peer review, and essentially the groups of scientists crowdsourced how they analyzed the data. And the main finding of this paper, the shocking finding, is that researchers analyzing the same data set for the same question came up with large variations in effect sizes. The point estimates for the odds ratio for effect went from 0.89 to almost 3. 2/3 of the group found a statistically significant effect size, and 1/3 did not. Now, this has huge implications for clinicians who are charged with translating evidence for patients. When you read a study in the medical literature now, the methods section usually reveals a sentence or two saying, we analyze the data in X or Y way. One way they analyze the data. Nosek's study suggests, especially, and this is really relevant for observational studies, there are many ways to analyze the data, and many of these ways are defensible, and these different ways may yield a different effect size. So I was so struck by this paper that I wrote a column on it, and in that column I offer examples of how this changes interpretation of evidence in the medical literature. But for instance, the next time you read a study that shows a hazard ratio of effect of 1.20, Nosek's work suggests that there might be many other ways to analyze the data, and maybe that effect size of 1.20 is an underestimate or overestimate. I hope you read my column, and then I hope you read and save Professor Nosek's paper. The main thing I learned from it is that if we want to get closer to the truth from one data set, it would be wise to do multiple analyses, such things as called a multiverse analysis. This is where one analyzes the data in multiple different ways and then publishes all the effect sizes. So when you look at the main figure of Nozick's paper, yes, you see that the odds ratios do vary, and some are significant and others are not. But what you do see is lots of overlapping confidence intervals. And when you look at the results in total, there is a trend towards a positive effect. So yes, soccer referees do give out more red cards to darker skinned players. So a commitment to open, transparent science would certainly make such multiple analyses easier to do. And of course, finally, the grand lesson of this newly discovered area of heterogeneity is that when it comes to medical science, uncertainty prevails over certainty, which is why I advocate so strongly for a conservative approach to medical practice. So that's it for this week in cardiology. I'm grateful that you listened. And if you like this podcast, please subscribe, rate us, and consider giving us a review. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org.